Welcome to the Tennessee Heart Health Network webinar. Our aim is to be your resource for innovative statewide initiatives to improve primary care for all Tennesseans. We hope that you enjoy today's educational program and share it with your colleagues to make a better impact of heart health in Tennessee.
All right. Well, good evening, everyone. I am Karen Baird, Director of Member Services for the Tennessee Academy of Family Physicians, and I would like to personally welcome you to tonight's webinar, Remote Patient Monitoring for Blood Pressure Control in Primary Care. This is the last in our series, the Primary Care Toolbox, and I want to thank the Heart Health Network for partnering with us on this series. If you are a member of the TNAFP, you are eligible to receive one prescribed CME credit for attending tonight. To receive this credit, you will need to complete a brief evaluation that will be emailed to you shortly after the webinar ends. Your credit will be reported to the AAFP when your responses have been received. Please keep your microphone muted unless requested to unmute during the presentation, and utilize the chat feature if you have any questions throughout the webinar. Now it is with great pleasure that I introduce tonight's presenter, Dr. Asos Mahmood. He is an assistant professor in the Center for Health System Improvement at the University of Tennessee's Health Science Center, College of Medicine, and serves as Director of Population Health Research Education for the Tennessee Population Health Consortium. Dr. Mahmood received his PhD in Health Systems Management and Policy and his Master of Public Health from the University of Memphis School of Public Health. He also earned a Bachelor of Medicine and Bachelor of Surgery degree from the University of you may have to help me with this one. Suleimani School of Medicine. Thank you. Dr. Mahmood's research is focused on the biophysical determinants of health, chronic medical conditions, healthcare disparities, and health services access and utilization among aging, low-income, and underserved populations. He is also interested in research, assessing, and evaluating the role of evidence-based interventions and health policies in prevention and improving health outcomes for patients with chronic medical conditions. His other research interests include examining impacts of health informatics and patient empowering tools, such as mobile health apps and telehealth, in enhancing the quality of life and quality of delivered care. Dr. Mahmood has presented his research at various scientific conferences and has successfully published in many peer-reviewed prestigious national and international journals, including the European Heart Journal, Health Services Research, Cancer Causes and Control, and Journal of Medical Internet Research. What a resume. If I've missed anything, please feel free to add. So at this time, I will turn it over to Dr. Mahmood.
Well, thank you so much, Karen, and good evening, everyone. I'm going to go ahead and start sharing my slides. Okay, so this evening we're going to talk about remote patient monitoring and its evidence-based effectiveness and the impact of using RPM among patients with hypertension. And also we'll cover effective strategies, and we'll talk about some reimbursement codes that can be utilized to sustain the implementation of RPM. So a couple of statements here. There is no commercial support obtained for this CME activity, and there are no individuals, and of course, no individuals in control of this content have any relevant financial or non-financial relationships to disclose. There are several products and companies mentioned in this webinar, and we have no financial or non-financial relationships to these companies or products. And this webinar in no way is a promotional or marketing webinar or presentation. And the sole purpose of naming those companies and products are just examples. And the presentation is completely based on scientific evidence. All right, there are several learning objectives for this presentation. And by the end of this presentation, you should be able to define the current state of hypertension control, and related statistics in the U.S. and Tennessee. I decided to, first paint the picture of hypertension and talk about the status, the current status of hypertension in the United States and Tennessee, and of course, the status of blood pressure control before talking about remote patient monitoring for hypertension. So one of the learning objectives is to define and learn about the current status of hypertension in the United States and Tennessee. And then there are several other learning objectives. So the second one is to investigate the existing disparities in hypertension prevalence and blood pressure control, identify and assess factors contributing to poor blood pressure control and adverse health outcomes among hypertensive patients, and then describe the concept of remote patient monitoring and assess its value in blood pressure control, analyze and interpret the evidence-based effectiveness of RPM, which is I'd like to use this abbreviation moving forward instead of the full phrase or the full name, remote patient monitoring, and describe the concept of RPM and assess its value in blood pressure control, analyze and interpret the evidence-based effectiveness of RPM for blood pressure control, distinguish available RPM resources and services, and then identify effective strategies to implement remote patient monitoring, or RPM, for blood pressure control. So let's start with some statistics. In the United States, about 48% of the adult population have hypertension, which this percentage is representing about 120 million U.S. adults. But I have to point out that this is based on the 2017 clinical practice guideline definition of hypertension. And as you see that, the cut point is standing at 130 over 80 millimeter mercury, which is quite different from prior cut points for hypertension. Priorly, for someone to be considered as hypertensive, they might have had a blood pressure standing at 140 over 90 instead of the 130 over 80. So by using this cut point, it's possible to capture to have a larger pool of adults with hypertension. So that's why we currently have about 120 million adults who are adults in the United States who are considered to be hypertensive. And if you look at the prevalence map of hypertension in the United States, you see that the impact is mainly the impact of hypertension, or the burden of hypertension, is kindly more felt in the southern states and the Appalachian region, And most of the counties in these locations have a prevalence of a hypertension prevalence is standing at about 39% or higher. So the burden of hypertension prevalence is not like equally distributed, and there are certain demographics and certain race and ethnicities who are mainly impacted and largely impacted. So, for example, considering the age breakdown, the hypertension prevalence is mainly or like higher among people who are older, considered as older adults at 65 years or older. And if you look at the breakdown by race and ethnicity, the highest prevalence is among the non-Hispanic Blacks, while the lowest prevalence is among the Hispanic adults. So there are like the disparities or differences across race and ethnicity. And of course, if you consider other demographics like certain socioeconomic status, people in poverty have higher prevalence of hypertension. And of course, across different educational backgrounds, you see there are like differences in the hypertension prevalence. People with more educational attainment have lower prevalence, while people with less education have higher prevalence of hypertension. And hypertension is, of course, a modifiable risk factor for many cardiovascular diseases, and one of the contributing factors for stroke. And if you look at the data in 2021, we find that hypertension was a primary or contributing cause of about 690,000 deaths in the US. Now, what about blood pressure control? So we said about 120 million US adults are considered as hypertensive, but how many are actually in that like category of having blood pressure control? Only 22% of the US adults who are considered as hypertensive actually have their blood pressure under control, just kind of a low percentage. And again, there are differences across different socio-demographic characteristics or across race and ethnicity. There are certain subgroups that have a really poor hypertension control. So, for example, non-Hispanic Blacks have the lowest percentage for having blood pressure control, followed by Hispanics, and then non-Hispanic Asians, and then, of course, the non-Hispanic whites. What about the trends over time? So on the left, you have a graph of blood pressure control among all adults who are considered as hypertension. And over time, when we start by looking at these, percentages that are mapped over here, early in the 2000s and towards the 2011 and 12, there are some improvements in blood pressure control among all hypertensive patients. And then, of course, among those who are on medication, there are some improvements. But then starting in 2011 and 12 and moving forward, the trends are reversing. So the blood pressure control proportions are the population proportion hypertensive of the hypertensive population is going down. And it's really sad to see these reverse trends. And there's like a study that investigated the current status of hypertension control by mapping the 2020 data. And based on their results, that is not shown here in this graph, it's like there's another downward, trend, or the trend is still going down, which is kind of sad to see these downward trends in blood pressure control among hypertensive patients. And, these numbers are pushing us to be more proactive in our efforts to come up with plans and probably strategies for blood pressure control, and probably work with hypertensive populations to adhere to medication, their medications, and work towards implementing successful strategies like remote patient monitoring to encourage patients and engage patients in blood pressure control strategies, and making them to be more engaged in their treatment plans. So what about the state of Tennessee? When we look at the prevalence of hypertension across different counties in the state, we see that most of the states have a really high hypertension prevalence. So percentage-wise, most of these counties are standing at a prevalence of 39% or higher. And by specifically looking at the rural counties, again, the prevalence is really high. And almost all of these counties have a prevalence of have a hypertension prevalence of 36% or higher. And of course, hypertension death rates for the state, the entire state, compared to the national levels, are really high. And for all the race and ethnic subgroups, when they're compared to the national level, the hypertension death rate is really high. And there are, again, variations across different race and ethnicities within the state. What about medication non-adherence? This map shows medication non-adherence for the older populations, the older hypertensive adults, especially Medicare Part D beneficiaries. We see that most of the Western counties are doing really poor in terms of in terms of medication adherence. So the non-adherent rates are really high in the West Tennessee and the counties surrounding Memphis. So multiple rural counties, of course, in this part of the state. So most of you are familiar with factors. I'm sure you've heard about that there's social determinants of health as root causes for many health problems or chronic medical conditions. And this graph over here just simply summarizes multiple where the determinants of hypertension and poor blood pressure control among hypertensive patients. So there are policy-related factors or the determinants, environmental factors, of course, adverse social determinants of health, and there are personal or individual level factors, healthcare or healthcare and health system related factors. Just to mention a few examples, like the social determinants of health, neighborhood safety or lack of green spaces within the neighborhoods that will, give people an opportunity to be engaged, more active and engage in physical activity. Poverty is another factor. Food insecurity and the lack of access to healthy and nutritious food. And of course, there are health system and healthcare access related factors like lack of health insurance or lack of preventive measures, lack of timely care, and lack of or not having like a personal healthcare provider. So these factors are all contributing to like a high prevalence of hypertension and poor hypertension control or poor blood pressure control. And of course, there are individual level factors like health behavior and lifestyle factors. So most of these factors are interconnected and overlap, and their impact has like exponentiates and as like there are many factors that impact in the individuals at the same time. And these factors, of course, when an individual is like having the challenge of dealing with hypertension and actually is having hypertension and poor blood pressure control, in turn, they might be or they will be at risk of adverse other cardiovascular problems, and so stroke, of course, as well. So there are multiple strategies that have been proposed for blood pressure control among people with hypertension. Like some of these strategies include strategies such as use of team-based care, implementation of lifestyle programs at the organizational community and policy levels, use of standardized treatment protocols, strategies encompassing improved medication acceptance and medication adherence, use of continuous quality improvement strategies, implementing financial strategies, use of anti-racism efforts. And at the top, you see accurate blood pressure measurement. And this is where you can have remote patient monitoring strategies or other strategies such as self-measured blood pressure monitoring, which is like I'll talk about it in a minute, because they're kind of self-measured blood pressure monitoring is just like quite relevant to our discussions about remote patient monitoring for blood pressure control. And in essence, remote patient monitoring is a form or a type of self-measured blood pressure monitoring. So strategies around accurate blood pressure measurement, we're implementing RPM for successful and accurate blood pressure measurement and timely feedback to patients, and acting upon blood pressure readings are listed under this outline strategy over here. So let's like spend a minute talking about self-measured blood pressure monitoring, because as I said, this is quite relevant to our talk and our discussion about remote patient monitoring for blood pressure control. So what is self-measured? All of you, I'm quite sure, are better, talking about self-measured blood pressure monitoring than me, because we quite have a lot of physicians over here this evening with us. So self-measured blood pressure monitoring refers to blood pressure measurement taken outside the traditional healthcare and clinical settings, either at home or when you're on vacation or at work or elsewhere. I actually have a blood pressure cuff here with me. which is like a form of uh, fully digitalized blood pressure cuff, which can be utilized for self-measured blood pressure monitoring. So this device is FDA approved and Bluetooth enabled, which allows me to link the device to my cell phone and smartphone and download an app there and track my readings. And I can easily share my readings with my primary care provider and, probably email those readings to my primary care provider. So this is one type of like a self-measured blood pressure monitoring device that could be utilized in remote patient monitoring. And of course, there are certain co-interventions that has been proposed or recommended to be utilized and implemented alongside self-measured blood pressure monitoring. So, for example, the patient counseling or engaging patients in active treatment plans or providing patients with telephonic or telehealth supported tools, and of course implementing telemonitoring tools or services alongside self-measured blood pressure monitoring, and maybe encouraging and engaging patients or patients with hypertension in educational classes. And the current evidence shows that although that self-measured blood pressure monitoring can be an effective tool in blood pressure control, but having co-interventions alongside self-measured blood pressure monitoring can have more impact in reducing blood pressure among people with hypertension, and they might have more benefits in terms of blood pressure control. And as I mentioned, RPM is a form of remote patient. RPM is a form of self-measured blood pressure telemonitoring, and can be labeled under one of the strategies of self-measured blood pressure monitoring. But the more formal definition or like a more inclusive definition for RPM is this one by the Agency for Health Research and Quality, which defines RPM as a type of telehealth in which healthcare providers monitor patients outside the traditional care settings using digital medical devices such as weight scales, blood pressure monitors, pulse oximeters, and blood glucose meters. So RPM has like many different types or versions, and although they can be utilized for blood pressure control and blood pressure monitoring among hypertensive patients, but at the same time, using different devices, of course, they could be RPM strategies could be utilized to monitor blood glucose, for example, among diabetic patients, or they could RPM devices and strategies could be utilized to monitor weight or utilized in weight management among the patients in need of weight management, or the people interested or people or patients who might benefit from implementing strategies to reduce weight, of course, or they might be interested in getting more active and at the same time track their own weight, or allowing their healthcare providers to monitor their weight as they move forward with a treatment plan or an educational physical activity session or something similar. And through the RPM technologies and RPM strategies, automated feedback and workflows can be built into data collection. Most of these, strategy the devices that are used in RPM services can be linked to an RPM specific platform, or they could be linked to the electronic medical record systems that can transmit data in real time. And I have to mention that most of these new generations of these devices are featured with specific characteristics like transmitting data in real time, because some of these devices operate on cellular networks, and they don't need Wi-Fi or internet connection. And this is one of the beneficial features of these new generations of the monitoring devices, because you might have a patient located in a remote area or a rural location that have poor internet connection, or they might not have access to Wi-Fi, but they might have a good cellular network in that specific location. So they can use one of these devices to transmit data in real time to their care teams or their healthcare providers. So there are a few recommendations for utilizing self-measured blood pressure telemonitoring and remote patient monitoring strategies. And the 2017 clinical practice guideline that were led by the American College of Cardiology and American Heart Association recommends the use of self-measured blood pressure monitoring, either alone or in conjunction with telehealth, utilizing telemonitoring features, along with the self-measured blood pressure monitoring, or other interventions, as I mentioned, utilizing, probably educational sessions or other sorts of successful interventions alongside self-measured blood pressure monitoring. So these strategies have shown success in controlling and reducing blood pressure among patients with hypertension. And the other recommendations include utilizing telehealth support strategies that could be used, in adjunction to other interventions. So, for example, telemonitoring features or telehealth services could be utilized alongside team-based care. And they have shown there's enough evidence to show that these strategies are, successful enough to help care teams and help patients at the same time. And these letters indicate that the current evidence is strong and based on high quality research, at least for the first recommendation. But for the second one, there's evidence is of moderate strength, but is based on high quality of research. And of course, if we explore the literature, there are a lot of well-conducted studies out there supporting the benefits of RPM and self-measured blood pressure, telemonitoring, and self-measured blood pressure monitoring, plus co-interventions. And so these published studies are mainly, systematic reviews or meta-analysis of randomized controlled trials, well-conducted randomized controlled trials. So the collective evidence in this area indicate that remote patient monitoring for blood pressure control and self-measured blood pressure telemonitoring can significantly reduce systolic and diastolic blood pressure when compared to usual care or self-monitoring alone. So people with hypertension can utilize monitoring devices for their own use, and probably without other versions of telemonitoring or remote patient monitoring. And there's evidence that even like using self-measured blood pressure monitoring techniques alone, there's like enough evidence to even suggest that strategy could be beneficial in terms of reducing blood pressure. But since our focus is on RPM and self-measured blood pressure monitoring, telemonitoring, we could based on the published studies and the literature, and of course the recommendations by American College of Cardiology and American Heart Associations, we can kind of confidently say that these strategies are effective in reducing blood pressure, and might help us and healthcare providers, and at the same time our patients, to have a better control of blood pressure. And other evidence shows that RPM and telemonitoring strategies are associated with increased medication adherence, reduced hospitalizations for people with hypertension, and reduced mortality. And as I mentioned, self-measured blood pressure monitoring alone might result in some small lead reductions in systolic and diastolic blood pressure in 6 months and at 1 year. But there's still a lack of evidence on long-term impact of these strategies. So we have to wait for more studies examining the long-term impacts of remote patient monitoring and self-measured blood pressure telemonitoring over longer periods of time. Currently, there are 4 main reimbursement codes, and of course, providing RPM could be sustained and reimbursed. So back in 2018, the CMS came up with these reimbursement codes. The first one is basically billing for this service as you'd be covering for the time spent on the initial device setup and patient onboarding for the RPM services. And of course, these are not specific to patients with hypertension. Any kind of remote patient monitoring service could be reimbursed through billing these codes. For example, people with diabetes, if you're tracking and monitoring a patient with diabetes and you track their blood glucose, you could again bill for the services provided. So the first code is like kind of covers the time spent with on the initial device setup and patient onboarding. And then the second one is billing for patient transmitted patient generated health data. So for this one to be able to bill, you need to have patient data for at least 16 days per month to be able to bill for that specific month. And the third code is for, or it covers the initial time spent on treatment management, or actual time spent with the patient discussing their, their readings, blood pressure readings, or discussing the treatment plan, and probably possible or potential modifications that need to be done, in terms of the treatment plan. And so this one is like billing for the first 20 minutes that is spent on the treatment plan or with the patient. And beyond this, the first 20 minutes, you could also bill for the 2 other additional episodes, each of 20 minutes, but you can't bill for more than 60 minutes spent on the treatment plan or with the patient in each specific month. And there's, of course, another standalone code, which is code 99091, which is like for one, like it doesn't have to be, it's kind of a separate code. And for these codes, you have to have like the first one established to be able to build for the second one, and the first 2 established to be able to build for the third and fourth. But for the fifth one, it's just like is considered as the standalone, CPT code. And if you don't have these, it's okay. You could still build for that, standalone service, RPM service. And but you have to have at least 30 minutes spent on the treatment plan or with the patient to be able to bill for the fifth, for that specific fifth code, which is not shown here. And of course, as I mentioned at the beginning of this session, this is not a marketing or a promotional session, but I just want to mention that there are available telehealth and remote monitoring companies that provide RPM services to patients with hypertension, and there are other telehealth supported care models like non-face-to-face chronic care management or annual wellness visits. Some of these companies provide those services. And they have their own platforms, and, their rationale behind their models is that physicians might not have enough time to spend on the billing aspect of the services, and they might not have enough staff and trained staff to deal with those billing codes, or go through the practical steps of like device setup and educational sessions with the patients, and actually working with the patients on, working or being a linkage between the patients and the healthcare providers. So that's the rationale behind their business models and their services. But at the University of Tennessee Health Science Center, we have like a sort of a cooperative agreement or a partnership with one of these telehealth companies. And the participating clinics and health systems in the Tennessee Population Health Data Network can benefit from this partnership. And because our data network, which is chronic disease data registry, is working as a backbone of this partnership. And so for the health systems and practices participating in this network, they can benefit from the partnership. So if they're interested in RPM services for patients with hypertension, or RPM services for patients with diabetes or other chronic medical conditions, they can work with us and work with the company to implement the RPM and enroll their patients. Because, as I mentioned, the data registries working as a backbone of this partnership, because the University of Tennessee will be able to, if we have access to your data, of course, and at least we have access to 19 health systems and practices across the state. And if one of these health systems and practices is interested in implementing RPM, we can identify patients who are eligible for, let's say, RPM for blood pressure control. We can identify people with high blood pressure or people diagnosed with hypertension, and walk with the health system or clinic and the company in a step-by-step manner to implement and identify patients and hopefully have a better outcomes for the patients and the clinics, of course. So if you are not part of the TNPOPNet, you can sign up. It's free. Yeah, the only obligation on your side is to give us access to your data, and of course that data will be transferred to our data registry through secure channels. But let's focus on the RPM implementation and how the steps, how our partnership with the company works, and how the data registry would help throughout the process. So if you're interested in let's say if you're part of the TNPOPNet data registry, or so you don't have to be concerned about the first step. If you're not part of the TNPOPNet data registry and want to benefit from our partnership and implement RPM services and enroll patients with hypertension, you have to sign up and become part of our Tennessee Population Health Data Network and provide us access with data. And then at that point, if you're interested, as I mentioned, interested in implementing RPM, you have to reach out to certain individuals at the University of Memphis, or you can contact Compwell. You can contact Compwell Company, the individual responsible, or the corresponding individual here. The company is Ricky Eccles, and at the University of Tennessee, Miss Annie Ninen, who manages the TNPOPNet data registry, or the director of measurement and reporting for the TNPOPNet, Dr. Satya Surbi, or you could contact me, and I'll be able to put you in touch with the right individuals to be able to benefit from our collaboration and partnership and implement RPM services and reach out to your patients with hypertension. And when you reach out to these individuals, you can state your interest and draft an email and let us know that you're interested in these services and you want to implement RPM, or you want to become part of the TNPOPNet. And then after that, the company will meet with you to discuss the, the services and of course, like anything related to your collaboration with the company. And then you'll complete a service agreement with the company. Then we'll be able to provide a list of eligible patients to you because we have access to your data and we can identify patients eligible to receive RPM services. So if you're like focused on hypertensive patients, we'll identify those patients for you. And then you will contact the patients afterwards and will let them know that this service is available, and patients will be given the option of like opting out of the service. For people who are not interested in the service, they can opt out. And then afterwards, we'll be able to provide, when we have like a certain number of individuals and patients interested in receiving the service, we can provide additional information to the clinic and the company on the patients. Like, looking at the data, we can identify other characteristics of these patients, and we can provide those information to the clinic and the company, of course. And then the next step would be, the clinic, where you would be providing information to the company, like probably contact information for those patients interested in receiving the service. And the company would work with the patients to, establish, the necessary establish the necessary steps, or, go through the process of establishing the service of the patients. And, patients need to consent and enroll in the service. And this information would come back to the clinic and the University of Tennessee. And they will have like proper documentation of this information. And afterwards, we'll receive, at the University of Tennessee, we'll receive RPM data. So we can produce quality improvement reports based on that for the clinics. And of course, we'll be able to work with the clinics, on like providing advice and reports on, their weaknesses and their successes, and, better strategies or, suggestions for their patients and the RPM implementation moving forward. So I'd like to stop there and open it up for questions. Thank you so much. If you have any questions, I'll be happy to answer your questions.
All right. Thank you, Dr. Mahmoud. Do we have any questions? I don't see any in the chat box.
I do have a question. So I'm Janet Cruz. I'm actually from Pennsylvania. I am a program director to a residency program, and this is something that we're looking to implement. I did have a question regarding, have you seen RPMs being implemented within just like the existing EMR? Like we're on Epic. Have you seen data going directly to an EMR using, the platforms that already exist without having to outsource to another company?
Yeah, I mean, that's really a good question. So most of the evidence is like current evidence is based on like individual and independent, implementation of RPM and self-measured blood pressure telemonitoring. So they're not like a company-based implementation, and the evidence is like based on like probably hospital sponsored implementation of RPM. So you could say that like the current evidence supports the idea of like if you're planning to have like your own RPM without depending on a company, I think that's totally fine. There's enough evidence to support your strategy to move forward and implement RPM. So although there are companies out there, you don't have to use those companies, but you just have to, have infrastructure to, if you're like thinking about billing for RPM services, you have to have like training and infrastructure to deal with the like complexities of that aspect of RPM. But in terms of successes and evidence-based implementation and, the current evidence out there, they're not like business supported RPM implementation or like company-based, although there's like part of the evidence is based on like and based on the evidence collected through those companies, but the majority of the evidence is coming from like independent implementation of RPM. And I have to say that like this current model of like everyone is jumping on like like creating a business model of telemonitoring and RPM. This is kind of new to the sphere, and we still have to investigate these models. And we actually at the University of Tennessee have plans to investigate and assess the impact of this where the RPM implementation through this partnership with Compwell. So we should be able to provide enough evidence on like the effectiveness of this model that is based on like reimbursement focused model of RPM. So, but to answer your question and to summarize, you could say that most of the evidence is coming from like independent studies, not like a company sponsored or a company specific model of RPM.
Hey, we do have a couple of more questions. Is Compwell a private company?
I think so, yeah. But we're not involved in any sort of payments, or we're not benefit. We don't benefit or from these service agreements that are like signed between the practices and the company.
And is there a cost to the patient at any point?
I think there's like a co-payment. There's like if I'm not mistaken, it's like a 20% cost sharing by the patients. But it's like again, going back to the prior studies in this area, these strategies have been shown to be cost effective as well. So in the long run, in terms of saving dollars and probably, the cost savings related to the implementation of RPM and probably saving on hospitalizations and, other complications, they have been shown to be cost effective. And probably if a practice or a clinic is going through the, is planning to go through the reimbursement path of RPM, the device implementation and setup might be cost effective for the patients as well.
Okay, so basically, like any other covered service with Medicare, their deductible and co-insurance would apply.
That's right. Yeah.
Okay. All right. And then we just have a comment that thank you. We are on Epic and in working with the informatics team to try to create workflows. So sounds like they're making progress, and we certainly wish you well there. All right. Do we have any other comments or questions?
Thank you, Dr. Mahood. This is Bob Casey. Hope you can hear me. I was so pleased to hear your presentation and glad that this is happening. I retired about 5 years ago, practiced most of my time in Oak Ridge, but I'm a Tennessee graduate myself, and I'm so glad that we're getting into things like this that can better and more effectively monitor patient's response to our treatment. It was a wild guess how well we were controlling people at home all these years going by. So my compliments to you and encourage you to press on with this. Thank you.
Thanks so much.
All right. And then we have another comment. Someone had worked with Welsh Allen BP monitors that have Bluetooth and an app, stating that could be an option.
Yeah, I mean, so let me understand the question better. We work, okay. Okay, is there a question there?
But I don't think it's a question. I think it's mainly just a comment.
Yeah, I mean, the Bluetooth. So, Bluetooth enabled devices. Since I'm interested in telehealth research, there's like always a concern about digital divide, and, people not having access to internet or Wi-Fi, and so Bluetooth, it can be like a good tool to connect to smartphones, but at the same time, there's always a concern about how to transfer data to care teams or healthcare providers. So probably these recently developed blood pressure cuffs and the newer generations of blood pressure cuffs, they have a feature of transmitting data in real time, probably it's better to transmit data through like these devices because they operate on cellular networks. They don't need internet or Wi-Fi.
Which is often poor in rural areas.
That's right. Yeah.
Yeah.
Probably overcoming the issue of digital divide.
All right. Do we have any other comments or questions for Dr. Mahmood? All right. Well, and seeing none, thank you again, Dr. Mahmood. We really appreciate this great information. Feel free to reach out to either me or Dr. Mahmood directly if you have any further questions or need additional information. We're happy to provide that for you. Remember to check your email and complete the survey evaluation. You will receive your certificate within a few days. The next webinar is scheduled for Tuesday, July the 9th, and is titled Using Data and Analytics to Improve Health Outcomes and Improve or Reduce Administrative Burden. So we really hope that you'll join us for that. Thank you again for joining us tonight, and this concludes tonight's session. Have a great week, everyone.
Thank you, everyone.
We hope that you've enjoyed today's webinar. For more information and resources, please visit our website, tnhearthealth.org. You can find more webinars under our resources page. You can also follow us on Twitter, LinkedIn, and YouTube. Please let us know if there are any specific topics or speakers that you would like us to present. Lastly, tell anyone you know who would be interested in helping to decrease the burden of cardiovascular diseases in Tennessee and share the webinar. Together we can achieve our goals of managing and preventing heart attacks and strokes for Tennesseans.